Good afternoon, and thanks for joining us for our Facebook Live today. I'm Christy with UT Southwestern, and we are here with Dr. Prapti Patel. She is a bone marrow transplant specialist and specializes also in the treatment of leukemia and myelodysplasia and also stem cell transplants. So thank you for being here with us today.
Thank you for inviting me.
So we just want to encourage you to ask any questions during this. We can't talk about specific cases due to privacy laws, but do feel free to ask questions. We would encourage that and share this conversation out with your friends. So my first question for you is, what is the most exciting thing happening in AML treatment right now?
I would say the most exciting thing about AML treatment is this new technology called next generation sequencing, where we can individualize therapy based on a patient's mutation profile. So about 30, 40 years ago, patients were diagnosed with AML and each patient was treated the same way. But with being able to identify separate mutations within all different types of AML, we now know that AML is a very heterogeneous disease. And there's actually about 30 different subtypes, and each type has a different prognosis and should be treated relatively differently based on the type of mutation a patient has. So we went from the treatment being the same exact way for the past 30, 40 years for every single patient diagnosed with AML, with now a patient being diagnosed, us reading their genetic code and finding mutations and then tailoring their therapy according to what mutations we find. And we find that this has actually improved survival. It has improved outcomes in terms of toxicities. There's some patients now that go from never having seen a hospital bed, from being a diagnosis of leukemia to never being admitted, not needing anything except just outpatient chemo. Whereas a couple of months ago, even patients were spending 3-4 weeks in the hospital just to get the same treatment.
That is incredible. So how do you determine when to treat a patient with that type of treatment?
So here at UT Southwestern, we actually treat all patients that way. So you come in the door with either a presumed diagnosis of leukemia or a known diagnosis of acute myeloid leukemia. And all patients will get this next generation sequencing, and within a few weeks we're able to tell them what mutations they have and what we think their prognosis is, and if there's any special targeted therapies that will allow for enhanced tumor kill or cell kill without all the toxicity that we've seen with past treatments.
So we have a question from Kristen. She wants to know, is AML inherited?
Certain forms of AML can be inherited. The bulk of new diagnosis of acute myeloid leukemia is de novo. What that means is patients have a normal bone marrow until one day a mistake is made in the replication of bone marrow cells and a leukemia appears. But we do see that there's about less than 10% of cases that are inherited, and they are due to inherited mutations in the bone marrow, and patients have a predisposition to developing either acute myeloid leukemia or myelodysplastic syndrome.
Wow. So I guess kind of going from there, I know a lot of these patients with AML end up having to get bone marrow transplants or more aggressive treatments. What does that look like, and how do you determine that that's the next step?
That's a great question because it actually ties in some of the newer technologies that we use for AML. So in the past, kind of going back in a historical perspective, patients that had AML, if they did not respond to therapy, we very quickly took them to transplant. But we were seeing that for patients that did respond to therapy, there were still quite a few that were relapsing after this initial therapy. So we know that there was something with each patient's biology of AML that they needed something extra, or they were okay with just getting chemo and not a transplant. So now with this new next generation sequencing, what we're able to do is give a patient a prognosis that your chance of relapse with just chemotherapy is X, and your chance of relapse with a bone marrow transplant is X. And generally speaking, when the chance of relapse with a bone marrow transplant is lower than a chance of relapse with just chemotherapy, we recommend a transplant be done for patients up front. Otherwise, if patients have AML and they relapse after they've completed their chemo, that kind of tells us, chemo is not enough and we need to do something extra, which is a bone marrow transplant.
Okay, looks like we have a question from Jared. So you kind of touched on how targeted therapy works. How new is this treatment, and is it available widely, or is it kind of specified to academic medical centers?
So targeted therapies were actually discovered in the mid-1990s. One of the most famous ones that people may know is Gleevec, or imatinib, used for chronic myelogenous leukemia. And from there was another targeted therapy called rituximab for non-Hodgkin's lymphomas. And that was pretty much all we had for quite some time until probably just about last year, where we started getting FDA approval for new forms of targeted therapies for acute myeloid leukemia. So some of the ones that have been approved so far are midostaurin or Rydapt for a FLT3 mutation with AML, and also enasidenib or IDIPA, which has been FDA approved for relapsed AML with a specific mutation called an IDH2 mutation. There's many more that are coming down the pike, and that's why this is so exciting.
What kind of clinical trials are in the works?
So right now, one of the biggest clinical trials that we're excited about here at UT Southwestern is a clinical trial called Beat AML. And it's a trial for acute myeloid leukemia patients that's sponsored by the Leukemia Lymphoma Society. And what they've done is they've brought together all different drug companies and the major academic institutions all throughout the United States. And what happens is a patient that is over the age of 65, when they come in with a new diagnosis of leukemia, we take a sample of their bone marrow, we read out their genetic code, and we find what mutations they have. And then we look for either therapies that are already in the works or are FDA approved, or we look for new novel therapies, which is really the goal of this trial, and try to match the patient's treatment to the mutation that they have, and then give them a targeted therapy. So right now, there's about 10 different arms to this trial. So it's a very rapid way to get a diagnosis, read the genetic code, and then plug the patient into an arm of therapy that is tailored to their particular type of AML.
So we have a question from Sierra, and I know you kind of touched on this when we were talking about bone marrow transplants, but she wants to know how targeted therapy is different than what was done before.
So what was done before, from anywhere in the 1960s up until probably a few years ago, is what we call cytotoxic chemotherapy. So these are chemotherapies that are conventional, and their job is to go in and kill a dividing cell. So they're not that smart, and what they do is they'll go in and kill any cell. So that includes all of the leukemia cells, but in addition, hair follicles, cells that protect the mouth, cells that protect the colon. So patients have immense horrible side effects from it. They can lose their hair, they have high risk of infection, they need transfusions of platelets and blood, and that's what requires this 1-month hospital stay. And so this has been the therapy that's been going on for decades. Now recently, with the targeted therapy, I like to call those smart drugs. So what smart drugs do is they know the difference between good bone marrow cells, good hair follicles, and they know the difference between bad leukemia cells.
Wow.
So if there's a certain mutation, those mutations are only going to be seen in the cancerous leukemia cells. So that drug will preferentially go and kill off that leukemia cell, leaving hair follicles, mouth, protectant cells, all those things intact, and so the side effects are much less.
So Anna wants to know, are there other applications for targeted therapy in non-AML patients?
Absolutely. So there are targeted therapies for acute lymphoblastic leukemia. There's also targeted therapies for non-Hodgkin's lymphoma and even Hodgkin's lymphoma. Many of these are FDA approved and are rapidly being incorporated into clinical trials and even in standard of care practices now.
So what's the future look like with that?
With targeted therapies?
Just covering, all of these different types of blood cancers.
I think the future is all about tailoring medicine and tailoring the specific disease that the patient has to a very specific therapy, and increasing survival rates and also decreasing toxicity. And the hope is that we cure these leukemias to the point where patients don't need to move on to bone marrow transplant. The therapies that we have are so good that they don't need to go through a transplant and everything that comes with a transplant afterwards.
We do have a question about bone marrow transplant. Resica wants to know, she says, I would like to know more about the bone marrow transplant. Who can donate and how do you become a donor?
So we'll start with how can you become a donor. There's 2 ways that you can become a donor. One of them is by becoming a related donor. So let's say a family member, usually a sibling or a parent or a child, is diagnosed with a blood cancer, and we want to do a related transplant. So usually there's genetic typing that is done for the patient and all their relatives, and if you're either a full match or a half match, we can call on you and ask if you would be willing to donate your stem cells. But the more common way to become an unrelated donor is to join the Unrelated Donor Registry here. So that's run by BeTheMatch.org. And it's very easy. There's bone marrow drives that happen all across the country on a daily basis, or you can just go to bethematch.org and they'll send you a kit to your house. You do a quick buccal swab, put the tube in the box and send it back to them. And so then there they just read out the genetic code and kind of keep it on a shelf. And then every time a patient is diagnosed with a leukemia or lymphoma and needs a transplant, if they don't have a related donor, we then contact the registry and ask them for another match that is unrelated, that would be fully matched to that patient. And then they'll go through the millions of people that are in the database and spit out results for all the possible donors that we have. If you are a Caucasian, there is a 70% chance that you'll be able to find a match in the donor system. And usually that's because donors kind of match up along the lines of race and ethnicity. And unfortunately, in the same donor bank, there's not as many representations of African Americans, Hispanics, Asians, and so the chance of a minority finding a match in that system is about 30%. So we always encourage patients, that anybody actually, to be a part of the registry, but really would appreciate more minorities coming into the registry because that increases the chance of a patient that's a minority of getting a match.
We have a question from Anna, and she wants to know, how does the transplant work?
So there's a few phases to transplant. The first phase is finding the donor, which is either related or an unrelated, and making sure they match. The second phase is to make sure that the patient is healthy enough to undergo a transplant. So we do what's called a pre-transplant workup. We check their liver function, kidney function, heart function, lung function, make sure they're healthy enough to undergo a transplant. And then is the actual transplant process. So what happens here is the patient is put into the hospital and they're given very high doses of chemotherapy, much higher than doses that we give for leukemia or lymphoma. And the job of this chemo is twofold. The first one is to empty out the bone marrow and basically make space in the bone marrow for the new donor cells to come in. And the second thing is, if the doses are given at high enough levels, that it can actually kill whatever microscopic leukemia, lymphoma, or MDS cells are left behind. And while the patient is getting this 4 to 5 day heavy-duty chemo in the hospital, the donor is actually getting collected. So they're getting shots in their belly or their arm of a drug called Neupogen, which is a synthetic form of a naturally occurring hormone that tells your bone marrow to hurry up and make nice, good stem cells. And when a healthy donor gets these kinds of shots or gets this Neupogen, their bone marrow goes into overdrive and just makes beautiful new stem cells that spill out into the blood. And once that happens, they get hooked up to what looks like a dialysis machine. So we put one IV in both arms, the blood is taken out, circulated through a machine, and all of the stem cells are removed, and then the blood is returned back into their body. So the donor is actually not losing anything vital that they've had. All the blood gets returned, the platelets get returned. All we're taking out are the stem cells that we force their body to produce with these shots.
So no side effects for the donor?
There are some side effects with the medication. So Neupogen is actually making the bone marrow go into overdrive. And the only other time that happens is when a patient has an infection, right? Or if even a normal person has an infection, the bone marrow is going into overdrive trying to kill off that infection. So donors can have low-grade fevers, they can have bone pain because the marrow is stretching, and their white blood cell count goes pretty high, so they feel like they have a flu-like syndrome. Now some donors don't get anything. Some donors do have quite a bit of bone pain that we can kind of manage with pain medications and things like that. So as the donor is collecting, the patient is in the hospital getting the chemo. And we time it so the chemo finishes right as the donor is finishing their collection. And then we give about 24 hours to the patient to let them clear off all this chemotherapy, because we don't want any of that chemo left behind in the patient, because then it would just damage the donor stem cells. And then that blood that we collected from the donor is taken to the lab, cleaned up, and it's just brought to the patient's room. And it's hung like a blood transfusion. And that's all that is. A lot of people think that a bone marrow transplant requires multiple bone marrows on the donor's parts or surgeries or anything like that, but really it's just a blood donation followed by a blood transfusion for the patient.
That actually answers Jared's question. He asked, is the transplant a surgical procedure? So it's not, it's just a transfusion, basically.
Yes, and the majority of the time it is just a transfusion. There are very select cases where we do what's called a bone marrow harvest on the donor, and that is a more involved process. That is a surgical procedure where the donor is taken to the operating room, they undergo general anesthesia, and we basically do multiple bone marrow biopsies and extract bone marrow directly from their pelvic bone. But with the technology we have now, we tend not to do that as much anymore.
Okay, Maddie wants to know, how long does it take before you know the results of the transplant?
We do, in terms of efficacy, I think that's what that question is getting at. We do different tests at different time points. So at day 30 after transplant, we check to see that the bone marrow is all donor and make sure that there's none of the patient's bone marrow cells left behind. We do that again at day 60 and then again at day 100. So day 100 is the big day. That's when we do a bone marrow biopsy. We do PET scans if we need to, just to make sure that patients are in remission. And at that point, we want to make sure that all of the bone marrow is all donor and no patients, because that tells us then that the patient's bone marrow has been obliterated and now it's growing this nice new healthy bone marrow that's replacing the cancer. And then we would do it again at 1 year when we do a bone marrow biopsy and make sure the patients are still in remission.
So if one bone marrow transplant doesn't work, can they receive another bone marrow, or can they undergo another bone marrow transplant?
Yes, so they can, and there's a couple things. So I think the question is probably asking more is what happens if the patient relapses after a transplant. There's a couple things that we can do. We can do what's called a donor lymphocyte infusion, where a lot of times we have extra white blood cells from the donor that are either stored away in the freezer for a rainy day, or the donor can come in and donate again. And we collect some more white blood cells, and then we transfuse them into the patient. And this time we're not actually giving stem cells, we're giving white blood cells, or lymphocytes. And that's because it's the lymphocytes that are responsible for getting rid of all of the cancer. The T cells in specific, when they see a abnormal cell, like a leukemia cell or a lymphoma cell, its natural reaction is to want to kill it. And so we then just give higher concentrations of those T cells, and we infuse them into the patient, try to get what's called a graft versus leukemia effect, where the new donor stem cells and the new donor lymphocytes are trying to go in and kill whatever relapse cells are there.
Okay.
The other thing we can do is a second bone marrow transplant too.
Do you know what is the success rate of targeted therapy versus, say, a bone marrow transplant?
So that really depends on the type of leukemia that you have. There are certain bone marrow cancers that are very susceptible to the graft versus leukemia or lymphoma principle. So that would include things like chronic myelogenous leukemia that is very sensitive to the graft versus leukemia effect. But at the same time, the targeted therapy for CML, which is Gleevec or dasatinib or Sprycel, they have like 90% response rates.
Wow.
And so doing a bone marrow transplant is actually obsolete for those kinds of patients. When you're looking at AML, the overall success of a bone marrow, if we're not taking into account all the mutations, I would say is about 60%. But depending on what type of mutations are present, we can actually push that up to like 80-85%, versus as low as 20%, depending on what mutations we have.
We do have a question from Andy. She's asking, what are the biggest myths you hear about bone marrow transplants?
The biggest myth that I hear is that a bone marrow transplant is a surgery. And I think that's probably, in addition to being a myth, it's probably the one big thing that keeps people from registering to be a donor, is that they're afraid that it's something that's very scary, it's a surgical procedure, involves a ton of needles and scalpels, but it's actually just a blood donation.
I know, I actually thought that before, and
Yeah.
then after talking to you and some other physicians, I learned that it's just an easy swab.
Yep, that's all it is a swab.
Let's see here. We have a question from Anna, and she says, when does someone need a bone marrow transplant?
People need a bone marrow transplant if the chemotherapy is not enough. So we know that there are certain kinds of mutations with acute myeloid leukemia where no matter how much chemo or targeted therapy we throw at it, it's going to come back. And that's because the patient's immune system, anybody's immune system, is supposed to be able to find cancerous cells and kill them off. That's one of the jobs of the immune system. But sometimes cancers are so smart that they grow in the face of an immune system, and that patient's immune system never sees it as bad, and it never kills it and allows it to grow. So the thought behind a bone marrow transplant is, well, let's just get rid of the patient's immune system and give them a brand new bone marrow to kill it off. And so when we know that the patient's immune system is not very good at getting rid of this cancer and the chemotherapy is not going to work, that's when we choose a bone marrow transplant. And we know that if they have mutations that tend to be chemo resistant, or if the cancer comes back after their chemo, we know that their immune system is not very good and we need to give them another one.
Okay, and I know you talked a little bit earlier about unrelated donors being kind of the second line of finding a donor, and you want to find a related donor first. Why is that?
So again, a bone marrow transplant is really just an immune system. We're replacing one immune system with another, and an immune system's job is to fight off what's different. And when you have an immune system that's lived in one body for so long and it goes into another patient, it's going to want to kill off even the normal cells. So it fights skin and liver and colon, and we don't want that to happen. That's called graft versus host disease. And so when we pick a donor that's related to the patient, we're picking an immune system that's different enough to kill off the leukemia, but not so different that it's going to start attacking the liver, the colon, and the skin. And when you look at related donors, you get half of your genetics from mom and half from dad. So there's a 1 in 4 chance that a patient and his or her sibling are a complete genetic match. But that only occurs 25% of the time. And we prefer that because the immune systems are more similar, and the chance of getting graft versus host disease are probably on the order of 20%. But not everybody has the ability to have a fully matched sibling, so that's when we go to the unrelated donor. And there we pick basically our 10 favorite genes, because we can't match everything since the parents are different. And we say as long as the patient and the donor match at these 10 spots, that's the donor we want. But we know that all the other genes are going to be different, so the risk of graft versus host disease goes up to about 30%.
And we do only have about 10 minutes left, so if you want to ask any questions, please make sure you're getting those in. We do have a question from V. Ivans. They say, I'm 70 years old and in good health. Am I too old to donate bone marrow? My blood type is O negative.
So recently there has been a lot of data on older donors, and we know that patients that are over the age of 55 to 60, their immune systems are a little bit more primed, meaning they're more active, and they tend to cause a little bit more graft versus host disease. So we generally don't take patients over the age of 65 at this point, just because it's more risky to the patients when they get a bone marrow from an older donor.
Okay, so we have a question from Stacy. She wants to know, how can bone marrow transplants help a patient with NHL who has a recurrence?
So it depends. There's 2 different transplants that we use for patients with non-Hodgkin's lymphoma. And the first one is called an autologous stem cell transplant. It's a little bit different than an allogeneic stem cell transplant. So what that does is it harnesses the principle of dose escalation of chemo. We know that when patients are first diagnosed with a non-Hodgkin's lymphoma, they get a medium dose of chemo, and most of the time those patients go into remission. But some of the time with the more aggressive forms of lymphoma, it comes back. And the thought is, well, if we gave a medium dose of chemo before, we got rid of it for some time. What if we gave a super high dose of chemo? Will we get rid of it forever? So that's great in principle, but the reason that's difficult to do all the time is because, back to what I talked about in the beginning, chemotherapy doesn't know the difference between good and bad, and it will just go in and kill everything. So if you try to give a really high dose of chemo, it's going to kill normal cells. So before we give that super high dose of chemo, we actually harvest the patient's own bone marrow and freeze it, and then put them in the hospital, give them the super high doses of chemo, and then we bring their frozen bone marrow back into their hospital room, thaw it out, and basically infuse it back into them. So that's an autologous stem cell transplant, and that's the majority of types of transplants that are done for non-Hodgkin's lymphoma. But then we have that small amount of, a small subset of lymphoma that's very aggressive and really does need the graft versus lymphoma effect from somebody else's immune system killing off their lymphoma. And those patients would get an allogeneic transplant just like a leukemia patient would.
Okay. I have a question here from Jaime. He's asking, tell me more about graft versus host disease. Are there ways to slow it down or control it?
Yes, so that's a really good question. The goal with the transplant is that we cure the patient's cancer, but we don't cause a whole host of other medical problems afterwards. And the number one cause of comorbidity after a transplant, besides relapse of their disease, is graft versus host disease. And so like I talked about, these new T cells that you get from the donor are not used to native tissue from the patient, and they're going to want to kill it off. So in the past, it was very low doses of chemo and immunosuppressants. So a lot like how a kidney transplant patient or a liver transplant patient takes their rejection medicine to keep their own immune system from rejecting their donor liver, our transplant patients are taking the same medicines, and that's suppressing their donor immune system from rejecting their own organs. And like I said before, it was about a 20 to 40% chance of getting graft versus host disease. So one of the newer therapies that's been developed is a strategy called post-transplant cytoxan, where on day 3 and day 4 after the transplant takes place, the patients get a low dose of chemotherapy. And the thought is that as the transplanted cells are going in, they're seeing all these new tissues, a new liver, new kidneys, new skin, and they're going to want to try to kill it off, and so they become very active. So we give this low dose chemo to kill off those really active, nasty cells that are causing the GVHD, only leaving behind the ones that are going to be quiescent and more tolerant of the patient. And so that has actually reduced the amount of acute and chronic GVHD that we see.
Wow. So that kind of goes along with Resica's question here. She wants to know, are there further needed treatments after the procedure? I'm guessing the bone marrow transplant.
So in the past, usually what we did was just what's called health maintenance care. We had the patients come in twice a week to look for infection. We had them come in to look for graft versus host disease. But we also see that a lot of our patients were relapsing afterwards. So we want to know what can be done to prevent relapse. And so now there's this strategy called maintenance therapy, where we give a lot of these targeted therapies to patients post-transplant, and that's being looked at in clinical trials, where patients with bad mutations that have a targeted therapy get a transplant, and then they get maintenance targeted therapy afterwards, and it keeps them from relapsing. Or there's other types of low-dose maintenance chemo that we do afterwards to keep them from relapsing.
And I know Carty therapy is a new emerging therapy for patients with leukemia and lymphoma. How often do patients end up needing to be treated with Carty therapy, and would that be something that would happen before a bone marrow transplant would be considered, or after?
It depends on what we're talking about. For patients, generally speaking, especially for lymphoma, since it is a newer therapy and it's relatively well tolerated, for patients that have a resistant type of lymphoma that has not responded to therapy and there's no good donor options, I think CAR T-cell therapy is a very good frontline option. But unfortunately for acute myeloid leukemia, we don't have that just yet, and it's something that's in the works because it really depends on the type of cell that we're targeting. So we haven't gotten that far yet.
And there are so many different types of leukemia that it would just depend on the type.
Right now it's acute lymphoblastic leukemia that can be treated with CAR T-cell therapy. And that's mostly done in our younger patients in the pediatric population and adults less than the age of 25.
Okay. Is that because of immune systems, or?
It was just tested that way, and I think it's now being branched out to older populations in clinical trials around the country now. Adults are have access to CAR T-cell trials with acute lymphoblastic leukemia.
Okay, so we just have about 3 minutes left, so I'm going to address some questions here. If we don't get to your question, make sure you still ask in the comment section. We'll try to get to it later. Anna wants to know, what are some recent breakthroughs and what is on the horizon?
So I think the recent breakthroughs are reflected in the recent FDA approvals of targeted therapy. So it was the anacitinib that we talked about, the Rydapt or the midostaurin, and both of those are for targeted therapies for acute myeloid leukemia, and also the post-transplant Cytoxan that's being done. It's really decreasing the morbidity and mortality of transplant and GVHD after the fact. And some of the breakthroughs that we're kind of hoping for, you touched on them, is the CAR T-cell therapy for all the different types of lymphoma and different types of leukemia that are out there.
Okay, and Jenny wants to know, how long does a transplant procedure take, and is it painful for the recipient or the donor?
Well, for the donor, I don't think it's that painful. It's got the few side effects that we talked about with the flu-like symptoms. For the patient, it varies on how complicated the transplant can be. So best case scenario, the patient's usually in the hospital for about 3 to 4 weeks. And that's because we give this high dose of chemo, kill off all of their bone marrow, and when we transfuse that new bone marrow, it takes about 14 days for it to start to, get into the bone marrow, set up shop, and start working. And so those 14 days are particularly difficult for the patient. So nausea, mouth sores, difficulty with ambulating, diarrhea, infection risk. But that's why they're in the hospital, because they have access to our excellent nursing care where we take care of all those side effects and kind of nurse them through until their bone marrow picks back up. If they ever develop graft versus host disease or infection, kind of depending on that, the hospital stay could be longer or more complicated.
Okay, well, I think we've gotten to almost all of the questions. So as we wrap up, is there anything you want to add that wasn't asked by either myself or our audience members?
Just a little bit about the passion of what I do. I think this is a very exciting time for acute myeloid leukemia. We went from having everybody live in a hospital for weeks at a time to having patients that are elderly over the age of 65 that normally would have a 3 to 6 month survival. We have older patients getting targeted therapies that are living years out, getting to see children getting married and grandchildren being born, and it's all because of the technology of these targeted therapies. And I think that's the most rewarding part of this job.
All right, well, thank you so much
No
for
problem.
joining
Thank
us
you.
today, and thank you to everybody that asked questions and tuned in. This chat will be available still on Facebook and on YouTube afterwards, and so be sure to share it out with anybody that might be interested. If you still have questions, go ahead and put those in the comments, and if we can find an answer to those quickly, we will go ahead and reply to you. But thank you so much for joining us, and we will see you next time.
Thank you.